and COVID-19 are two different diseases. As you can see here, the R0 number, which is the number of people that we pass on in flu, is 1.3, while COVID-19 is somewhere from 2 to 2.5. The incubation time for flu is 1 to 4 days, but for COVID-19, it is said is 1 to 15. But most cases is about 5 to 7 days. So 5 to 7 days is the incubation time. Hospitalization rate is very much higher compared to flu. It's 19% versus 2%. And as I mentioned earlier, case fatality rate again is extremely high compared to flu. So it doesn't seem to be just a flu. With regards to case fatality rate, again, there is some difference with regards to the case fatality rate. In seasonal flu based US data, as you can see here, the seasonal flu, about 1.4% of the medical visits, the mortality rate in 65 years is high. But if you can see here, the mortality rate for everybody is 2.3% compared to 0.1%. I mentioned this earlier. And you come on to the more than 60 years of old, the mortality rate goes up to 6%. It is 4 to 7 times higher than flu. And so older the age group, higher the case fatality rate, right? And again, showing the same thing again based on Chinese CDC data, which shows if you're 80 years or older, right, you have a higher risk compared to someone younger. In fact, 14.8% of the people aged 80, or 15% of people who age 80 and older will succumb to this disease. If it's 70 to 79 years of age, 8% of them will succumb to the disease. If 60 to 69% of age gets the disease, 3.6% will succumb to the disease. This is based on US CDC data which is about over 50,000. Sorry, Chinese CDC data with over 50,000 patients data. Okay. As I mentioned earlier, again, China CDC tells the same story. Asymptomatic cases 1%, mild cases 80%, severe cases 15%, critical cases is 3%. Our first impression is that COVID-19 behaves like flu in the first week. Some, but not all, go on to get a SARS-like severe pneumonia. So majority have a flu-like illness, but some go on to get SARS-like illness, right? And usually, so what happens is in the first week, that's many people with mild disease. Towards the end of second week, those who destined to become ill get on to have the disease day 6 onwards. Day 6 onwards, they turn ill. Right? We classify clinical categories based on asymptomatic, no pneumonia, pneumonia not requiring supplemental oxygen, pneumonia requiring oxygen, and 5 critically ill. That's our clinical categories that we use in our hospital. So every patient that comes in, we categorize them based on that. So how do we treat them? Asymptomatic or mildly symptomatic, no treatment is necessary. Mild to moderate disease, we use hydroxychloroquine or chloroquine current treatment. Okay. Beyond this, we don't know yet what is the best antiviral treatment, or even if an antiviral treatment makes a difference, we don't know. And so we have some treatment strategies, but we don't know which one is the best. And so we are still trying out different strategies for particular disease. What is the evidence for chloroquine, hydroxychloroquine? If you believe Donald Trump, of course, that's the best thing that happened to COVID-19. But we're not sure as it, because the evidence for it out there is extremely poor. Okay, these are 3 papers that we have to go for COVID-19 and chloroquine, hydroxychloroquine. There's a letter to the editor from pharmacists from China saying that chloroquine seems to be effective. There is an in vitro study that is comparing hydroxychloroquine and chloroquine and came up with optimized dose regime. And this particular study from France that sort of hit the press and was actually viral everywhere, that talks about hydroxychloroquine and azithromycin. I will share with you bit of the data from this particular study. So there's just 26 patients. 6 of them were lost to follow-up. I think 4 or 5 of them ended up in ICU. So they are not, once they go to ICU, they don't follow them up. And so 6 of them lost to follow up. And so you're left with 20 patients who are on this treatment. 16 controls, not randomized controls. These are people who refuse to take the drug from a different hospital. They excluded people with retinopathy, G6PD deficiency, and QT prolongation. Breastfeeding and pregnant patients were also excluded. So there's a lot of the risk factors were excluded. So they ended up having 20 patients given hydroxychloroquine. As you can see here, the age, the hydroxychloroquine people were older, the control patients were younger, and many of them actually very mild disease. As you can see here in the hydroxychloroquine arm, 2 of them of the 20, 2 of them were asymptomatic, 12 of them only had a URTI, and 6 of them had pneumonia. Right? So this is a very mild disease. Time between onset to starting hydroxychloroquine is about 4 days. So anywhere from 2 days to 6 days, where that's when they started the hydroxychloroquine. And when they started these patients, what happened? They showed the viral, because these patients had mild disease, and so no brainer, all of them did very well. And so they looked at proxy markers, because if you do badly out of the study, if you enter ICU out of the study, so they only looked at people who remained in the wards, and they looked at the time taken for the viral load to become low, and they showed that hydroxychloroquine, the viral load really comes down. And then coincidentally, they had few patients, 6 patients, just 6 patients on azithromycin, because they were treating them for atypical pneumonia too. And they showed that if you had hydroxychloroquine, azithromycin, the viral load dropped faster. I just want to point out to you that if you go to read hydroxychloroquine literature, azithromycin is one of the contraindicated drugs because both of them prolong the QT interval. So to know the safety of hydroxychloroquine, azithromycin in this population, we need to. I'm always wary of treatment studies that come out saying one treatment is superior to the other. This is because of our Kaletra experience. I'll just share with you our Kaletra experience. Our lopinavir, ritonavir that we started. In the first wave of patients that came in, when patients were very ill, we gave them Kaletra. And in fact, I remember telling my own bosses, we started Kaletra and patient improved. We did see patients on face masks and then almost intubating, and they all got better. And we were convinced, at least in severe disease, Kaletra should be the treatment. There is just last 2-3 days ago, there's a randomized study published by the Chinese colleagues where they looked at Kaletra in moderate severe in patients who required oxygen, the exact group that we used. The Kaletra arm did just as well or just as badly as a placebo. There's no difference. And so I'm always wary about these uncontrolled studies that are coming through, because for Kaletra, we had that experience. In this disease, switches off in some people. And so just because we start a drug doesn't mean the switch off because of the particular drug. And so that's why we are very wary of coming up with treatment guidelines that we're not convinced about. Currently, what we are convinced about is hydroxychloroquine probably should be used for mild to moderate disease. We are not convinced it can be used as prophylaxis. We are not convinced we should use it for asymptomatic people because it is a drug with lots of side effects, especially the QT prolongation. We need to use it and see before we decide it is worth pursuing. So moving forward, what do we expect with regards to disease control? Every day deaths are mounting, and of course, there's concerns that whether it will be one of those flu pandemics that everybody always cares about. As you can see here, the Spanish flu mortality was extremely high, 17.4 million. The Asian flus as anywhere from 1.54 million to 2.4 million deaths. And so we really don't know how this disease is going to pan out, but it does look like it is going to be one of the, in recent times, one of the worst disease that we can sort of experience. Some of the reasons why it is so bad is this particular study that looked by the Japanese, who looked at looked at 28 pairs where the literature was very clear about who was infected first and who was infected second. So they knew exactly the series. So when they looked at 28 infectee series that was published, they said that the median serial interval is 4.6 days. That means if I get a disease now, and I got a family member next to me who stays with me throughout, and no way they can escape from infection, they will get the disease in 4.6 days. That's extremely fast, because before we can institute control, identify the person and isolate them, they've already infected somebody else. This is in contrast with the initial reports that came out from China, which said that probably the serial interval was 7.5 days. Just to remind you, SARS, based on Singapore data, the serial interval was 8.4 days. So we have a disease now that spreads very fast. Before we know you have the disease, you already passed on to somebody else, and that's the disease we have. And also, we are now seeing that that maybe there is some asymptomatic proportion of asymptomatic patients who are now also transmitting the disease, and so there is some story about whether there's also transmission. With regards to the mortality, I just want to share with you this particular data that is this particular data that is available here. As you can see here, each row, this is mild cases, mild pneumonia, this is severe, and each column is different, right? Mild cases, mild pneumonia, severe pneumonia. So mild cases, the mortality is 0.32. Mild pneumonia, the mortality is 0.48. If it's severe pneumonia, 7.73. No brainer, right? Isn't it? If you severe pneumonia, you have higher mortality. But what I want you to highlight is down here, the last three rows, right? Okay. Same severe pneumonia, but in Wuhan, the mortality rate is 10.28%. In Hubei province, outside Wuhan, 7.35%, and outside Hubei is 1.3%. So same disease, same severity of illness, different mortality, right? And so it just tells us that this disease kills by overwhelming our health system. The disease in itself is maybe not that fatal, but it can be extremely fatal if our health system gets overwhelmed. That's the reason why so much effort is being put to increase our surge capacity. Like no other times ever I have heard of private hospitals, university hospitals, army hospitals, and their labs are coming together in circumstances I've never seen before. That they're all coming together and pooling the capacity for this COVID-19. And if we can pool very well, and if we can make sure the disease doesn't overwhelm our surge capacity, then I think the mortality rate will be very low. And places where it happens, the mortality rate is actually because of surge in the capacity. Right? That's the reason. That's what people talk about, flatten the curve, right? And so we don't want it to come in a big surge, and then this is our hospital capacity and overwhelm the hospital capacity. We want it to come gradually. That means, what does it mean? That means we are in for a long haul. We are not going to see this outbreak finish in a short time. We want to flatten the curve so that it goes on for a longer time, but it doesn't overwhelm our health system. And that's the theory that we are working on, and to decrease deaths in the country. And how to flatten the curve, And one of the biggest things that people talk about is social distancing. Doing social distancing early in the outbreak might help, and that's the reason why some of the drastic measures that are being taken currently to control the disease. Okay? So there are three things that people do for this pandemic. One is isolation. So isolation is, if somebody's got a confirmed infection, then we isolate them so that they don't infect other people. The next one is quarantining them, right? We think somebody's been exposed to an infection but are not sick, we want to quarantine them somewhere. They are well, but they've been exposed to infection. We want to quarantine them. And of course, the social distancing, all the rest of the people, we want to do social distancing. And that's the three things that we want to continue. So even if we go into mitigation phase, we still have to continue all these three things. Any one of them alone is not enough to control the disease. And some of the things that we tell them when they go on home surveillance is when they ask them to do home quarantine themselves is what we do, right? We ask them to be contactable, limit their visitors, make sure they cough etiquette, wear a mask, wash their hands frequently, avoid sharing eating utensils and personal hygiene items, and of course, keep the windows open for good ventilation. These are the ones that we talk about when you have to isolate yourself at home. And many of us have got lots of theories on how best to control this, how to get over this pandemic, right? Isn't it? All of us have some theories, and each one thinks theirs is right. And so similarly, I have a theory too, and of course, it's just I'm not sure whether I'm right or wrong. And the theory is, I think to get out of this pandemic, I think we should form a cocoon around our high risk population, because every high risk, if a person who is not at high risk, let's say a young guy gets infected, maximum it gets a URTI or a mild pneumonia and he gets better. Yes, a small fraction of them end up in ICU and even succumb, but there's an extremely small fraction. But if the same infection happens in older age group, people who have got comorbids and people who have got low immunity, they end up in an intensive care unit, and they occupy a lot of intensive care beds, and the outcome is extremely poor. And so the way we're going to get out of this pandemic is we need to form a cocoon around all this group. We should make sure all these group of people do not get infected, no matter what. So maybe we have to make sure they stay at home, and the young and healthy ones provide for them so that they can remain at home until this pandemic is finished. And so forming a cocoon around our high-risk group is going to be a strategy to prevent this disease from overwhelming our healthcare system. There's a lot of advice now available on these are the QR codes for you to share, to refer to. This one is from public advice. A lot of courses available for public advice, and our guidelines are being regularly updated. And I didn't talk about the guidelines just now because we are in the process of coming up with the new guidelines. If you have any questions on the guidelines, you can ask us, but it's not out yet, and I didn't want to preempt the new guidelines. Right? And also, Ministry of Health has a Telegram channel in which they send out regularly updates on what Ministry of Health is coming up with. The CPRC comes up with it, and it's worth joining this group so that you get all the updates from Ministry of Health. And that's all I have for you now. Thanks. And that.
There's going to be a discussion after we have.
Before we move on to the next speaker, I kindly request your cooperation to please mute your mic on your side. So next, I would like to invite Dr. Suraya Amir Hussain, who is the Head of Infection Control Unit of the Medical Care Quality Section, Ministry of Health. She'll be presenting on infection prevention and control in the private healthcare facilities. Go ahead, Dr. Suraya.
Thank you, Dr. Fazila. Assalamualaikum warahmatullahi wabarakatuh dan salam sejahtera. Very good morning. Okay, my outline of the presentation will be introduction of COVID-19, case definition of COVID-19, a definition of contact, admission criteria, infection control. Under the infection control will be infection hierarchy of control, principles of infection prevention and control for acute respiratory infection, standard and transmission risk precaution, PPE recommendation, and also disinfection. In terms of guidelines in terms of case definition, as well as admission criteria. This is the current one. It will be updated, and later, if we have the latest one, we will share the latest one. As for this presentation, it just follow our version 4 of our protocols. Introduction of COVID-19. Coronavirus, COVID-19 is defined as illness caused by a novel coronavirus, now called severe acute respiratory syndrome coronavirus, SARS-CoV-2, which is formerly called 2019 nCoV, which was first detected amid outbreak of respiratory illness in Wuhan City, Hubei province of China. Coronavirus is an enveloped positive single-stranded RNA viruses that are round and sometimes pleomorphic with 80 to 120 diameter and belongs to the family of Coronaviridae. As you can see there, a short evolutions of COVID-19. Sorry, I forgot to put one more. Okay. It started in December 2019, where Chinese authority alerted WHO about outbreak in Wuhan. And in January 2020, 2019 coronavirus was identified. And in January 13, first case outside the China has actually detected in Thailand, Nepal, Japan, and South Korea. And in Malaysia, first cluster was detected in 25th of January 2020. The transmissions of this coronavirus, it's actually from person to person spread. The virus is not to spread mainly from person to person between people who are in close contact with another person, which is actually about 6 feet away, through the respiratory droplets produced. Through the respiratory droplets produced when an infected person cough or sneeze, and these droplets can land in the mouth or nose of people who are nearby or possibly be inhaled into the lungs. It can spread from contact with contaminated surfaces or objects. It may be possible that a person can get COVID-19 by touching a surface or object that has the virus on it, and then touching their own mouth, nose, and also possibly their eyes. This shows the infographic of the transmissions of the virus COVID. As you can see there, when infected individual cough, it actually produces the droplets. The droplets can be transmitted to susceptible individual, or droplets can also be landed on the surface, on your hands, which can be actually direct contact to the person and indirect contact to the environment. Some of the procedures, which is AGP, aerosol generating procedures, it can actually cause airborne, in which these droplets can become airborne so that it can actually transmit to the susceptible individual. This definition of COVID, following the current case definition for Malaysia, PUI of COVID-19, fever or acute respiratory infection with sudden onset of respiratory infection with at least one, whether it's shortness of breath, cough, or sore throat, and travel to or reside in affected countries in the before the onset of illness, or close contact in 14 days before illness onset with a confirmed case of COVID. Confirmed case of COVID is defined as a person with laboratory confirmation of infection with COVID-19. Definition of contact. We need to know this definition of contact, whether there are close contact or casual contact in terms of contact tracing as well as in terms of management of patient. A contact of COVID-19 case is a person not currently presenting symptoms or who has or may have been in contact with a COVID-19. It is divided into close contact and casual contact. The close contact are those who are, it could be healthcare associated exposure, who without wearing appropriate PPE, including providing direct care for COVID-19 patients, working with healthcare workers infected with COVID-19, visiting patients or staying in the same close environment of a COVID-19 patient. Those who are working together in close proximity or sharing the same classroom environment with COVID-19 patients, and those who traveling together with COVID-19 patients in any kind of convenience. And it could be from a group of people who are living in the same household as COVID-19 patients. As for casual contact, it could be a person who was in a close environment with a COVID-19 case for less than 15 minutes or at a distance of more than 2 meters. Or a person having face-to-face contact with COVID-19 case for less than 15 minutes at a distance of less than 2 meters. Admission criteria, this is the current our admission criteria. PUI COVID-19 who is critically ill, PUI COVID-19 with uncontrollable medical conditions, whether they are immunosuppressed status, pregnant women, and extreme age of less than 2 years or more than 65 years old. Symptomatic close contact of a confirmed case regardless of severity of illness, laboratory confirmed case whether they are symptomatic or asymptomatic, and those who are not suitable for home surveillance. As example, no carers, stay at hostel, no private transport. Okay. This is the hierarchy of controls in infection as a whole, as a general. We start with the biggest portion, which is eliminations of the hazard itself, substitution, which is replacing the hazards, engineering controls, isolate people from the hazards, administrative controls, change the way people work, and the last one is actually the PPE, protect the worker with personal protective equipment. From the most effective to the less effective, yeah? Principles of infection prevention and control for acute respiratory infections. This is as a principle for RE. Whenever patients have RE symptoms, these principles apply. First one, early and rapid recognition and source control that includes promotion of respiratory hygiene, application of standard precautions for all patients, additional precaution in selected patients, examples, contact, droplet, and airborne, based on the presumptive diagnosis, establishment of an IPC infrastructure for the healthcare facilities to support IPC activities, and provisions of adequate and regular supply of PPE and appropriate training of staff using the PPE. Okay, it will serve to further reduce the risk of transmissions of respiratory pathogens to healthcare workers and to other people interacting with the patients in the healthcare facilities. Looking into these current conditions, we can't actually predict whether there are patients are PUI or not, because some of them are not telling the truth. So please treat all the patients who comes with RE with these principles of infection prevention and control. We start with standard precaution, because standard precaution is very important. Okay, what is standard precaution? It is the minimum infection prevention practices that should be used in the care of all patients all the time. So don't forget about all patients all the time. Standard precautions are sets of infection control practices used to prevent transmissions of diseases that can be acquired by contact with blood, body fluids, non-infecting, and mucous membranes. This is our main thing in infection prevention and control. There are 9 components of standard precautions or elements in the standard precaution. The first and foremost is our hand hygiene. We can do it either by using alcohol-based hand rub or also using soap and water. Personal protective equipments, there are a range of personal protective equipments which actually used based on the exposure risk. Disinfectant and sterilizations, environmental hygiene, linen management, waste management, spillage management, injection safety and shops management, respiratory hygiene, and cough etiquette. So all these standard precautions is very, very related to our COVID-19 control and prevention. what are these transmission-based precautions? Okay, when treating patients who are known or suspected of being infected or colonized with infectious agents, it is applied according to the clinical syndrome and the likely etiologic agents, and then modified based on the test results. These precautions are to be implemented in conjunction with standard precaution. So this is actually together with the standard precaution. Standard precaution is the main thing you have to do. When we assess the patient, we need to see what types of transmission of these pathogens. So you can actually include this as a conjunction to the standard precautions. There are three types of transmission-based precautions. The first one is contact, the second one is droplet, and the third one is airborne. Okay? It may be combined for diseases that have multiple routes of transmissions. I'll be talking on contact precautions. Okay, for contact precaution, I'll just share you all the organisms related to that. Herpes simplex, herpes zoster, MDROs, Streptococcus disease, and also typhoid and varicella zoster. In terms of contact precautions, we should have the signage for that. For visitors, report to nurse before entry, hand washing of all patient, environmental contact and glove removal. Gloves required for all patient, environmental contact also. Long sleeve gown required for all patient and environmental contact also. For contact precautions, the first thing first is isolate the patient in a single room. If single room is not available, cohort the patient with the same organism at the designated area. Strict hand hygiene before entering and upon exiting the patient room or area. All patients need to be tagged for easy identification. Examples in their medical records as well as bedside area. Should be using appropriate PPE as well as dedicated medical equipment. For droplet precautions, the SARS-CoV-2 is actually included in this. You have to note that we need to apply airborne precaution in some of the procedure, which is actually aerosol generating procedure. Yeah? The droplet precautions usually related to outpatient and emergency department should include place acute febrile respiratory symptoms patients at least 1 meter or 3 feet away from others in common waiting area. Place visual alerts at the entrance of healthcare facilities instructing persons with respiratory symptoms to practice respiratory hygiene of cough etiquette, as well as provide hand hygiene resources. Tissues and masks must be made available in common areas, and areas should be used for the evaluation of patients with respiratory illnesses. I'll be focusing on IPC measures when dealing with PUI for COVID-19. Okay. For the clinical triage, we should have rapid case identification of patients at risk by using visual aid and proper travel history taking in patients presenting with fever and cough. Rapid triage of patients with acute febrile respiratory disease is recommended. Must offer surgical mask if patient is able to tolerate. If patient is unable to tolerate, advise patient to cover nose and mouth during coughing or sneezing with tissue or flex elbow. With our current condition, most of our patients who go to OPD is actually this group. They are having signs and symptoms of respiratory infections, so we need to offer them surgical masks to protect ourselves. Separate PUI to a dedicated waiting area, which is well ventilated, with special separations of at least 1 to 2 meters between patients in the waiting rooms. Place this PUI in the pre-designated waiting area, get the patient's information, notify to the district health office, then refer to screening hospitals. Okay. After that, we need to disinfect the waiting area. The pre-designated area should have actually 1 meter away from other patients and staff, and with minimal surrounding items. These are the PPE for healthcare workers recommended based on the exposure risk. Yeah? The first setting is the triage area. For healthcare workers who are working at the triage area, they should maintain 1 to 2 meters social distance at all times. The type of PPE recommended is surgical mask and also frequent hand hygiene. Full set of PPE should be made available at the site in case of emergency. So you need to keep full set of PPE nearby. If anything happens, patient collapse at the time, you have that, you can actually put it on and actually manage the patient there. Okay, in the patient waiting area, for patients, those who are with respiratory symptoms, patients should wear a face mask and should be seated at the designated area and to sit at least 1 meter apart. There will always be 1 meter apart as a social distancing, but this is patient's area also. Okay, the second setting will be the examination room or consultation room. Okay, for healthcare workers who are in that particular room, while they taking the history, doing the physical examination, as well as providing care, okay, they should wear surgical mask, minimum of surgical mask. They also need to use a frequent hand hygiene. Patients should be reminded to wear a surgical mask also if they can tolerate. If it's not, advise patient to cover nose and mouth when the healthcare worker enters the room. Okay. For cleaners who are doing the cleaning of the examination room, cleaning in the outpatient consultation rooms, okay, they should wear surgical mask, long sleeve gown, plastic gown, glove, as well as eye protection and closed shoes. Yeah, for the cleaners, they should actually increase the frequency of cleaning at areas with higher environmental contamination. This is from Wipro. They showed in various areas, as mentioned earlier. For the triage area, minimum of medical masks. Then for those who are involved in the collecting respiratory specimens, which is more of the clinic kesihatan as well as the hospitals, they need to wear face shield or goggles, medical mask, gown and glove. And for carrying patient or PUI or confirm, they should minimally wear use face shield, medical mask, gown and glove. For aerosol generating procedures, they should wear goggles or face shield, N95, gown and glove. And those who are transporting the suspected or confirmed cases, minimally they should wear goggles and face shield, medical mask, gown and glove. Okay.
Yes.
Sorry, hold on, we are having some technical glitch. Just give us a moment. The slides should be up in a moment.
Italian hospital makes heartbreaking decision not to intubate anyone over the age of 60.
怎么练？
既然你60岁了，你在家也是一样，你去医院也是一样的，没有人会反对你。
Kindly, if the participants could mute your microphone.
The next slide is on disinfection. Okay. Clean and disinfect surfaces likely to be contaminated and frequently touch surfaces. Bed, frequently touch surfaces in patient care environment such as doorknobs, surfaces and surrounding toilets. Minimum requirement of cleaning and disinfection of at least once a day and more frequently if visibly soiled. Disinfectant recommend
Jadi masalah sebab situasi ini apa kita masih lagi dalam situasi
mute.
contamination or spills. Higher dilutions of EPA registered disinfection is recommended, such as sodium hypochlorite 10,000 ppm. For reused equipment, which is not visibly soiled, wipe the external surfaces of large portable equipment, example X-ray and also ultrasound machines, and reusable respiratory equipment is actually this is in the next page, yeah. Okay, a little bit of terminal cleaning because those patients who are confirmed COVID-19, the area should be cleaned through terminal cleaning. This is the procedure for the terminal cleaning. Before entering the room, cleaning equipment should be assembled before applying PPE. Meaning everything is there, then start applying the PPE. PPE must be worn or taken outside the patient room or bed space. Yeah, cleaning must include portable carts or built-in holders for equipment. The room should be decontaminated from the highest to lowest point and from the least contaminated to the most contaminated. This is the procedure of terminal cleaning. Okay, you should remove the curtains and place in the red linen bag with alternate plastic after patient is discharged. This is the procedure that being conducted in the hospitals. We should use disinfectants such as sodium hypochlorite to do the terminal cleaning. Surface must be free from organic soil. Before we use the disinfectant, the neutral detergent solution can be used to clean the environment prior to disinfection. A combined detergent as well as disinfection also can be used, yeah, before we start the terminal cleaning. For cleaners who are doing the terminal cleaning, this is the PPE recommended. First, surgical mask, long sleeve gown, glove, eye protection through goggles or face shield, as well as boot or closed shoes. These all 5 is actually recommended PPE for the cleaners to protect them from getting transmission from COVID-19. Okay. The active ingredients and their working concentrations effective against coronavirus. There are a list of ingredients. The first one is accelerated hydrogen peroxide, 0.5%, benzalkonium chloride, 0.05%, chlorothalonil, ethyl alcohol, iodine in either 4, isopropanol, povidone iodine, sodium hypochlorite as well as sodium chloride. With the percentage. To prepare the disinfectants, okay, if you're using 2.5 gram disinfectant tablets of using concentration of disinfection of 10,000 ppm, you should use 7 tablets in a water volume of 1,000 ml for the usage of spillage management, wiping and cleaning of blood and body fluids on surface of non-critical items. Okay. For wiping of external surface of soil linen bag, we should use a concentration of disinfectant of 5,000 ppm, which is 0.1%. You need to have 4 tablets diluted in a 1,200 ml of water. For general cleaning, a daily routine cleaning, you only need 1,000 ppm of a concentration of 0.1%. Only 1 tablet of 2.5 milligram is actually needed. in a water volume of 1,000 ml. Okay. For other items used in the clinics as well as the outpatient settings, blood pressure cuff recommended action is actually wipe with low-level disinfectant. Examples of 70% alcohol or hypochlorite solution of white wipes. Okay, it should be used in between patients. So each of once patient go from your clinics, you should actually wipe the blood pressure cuff. For stethoscope, wipe with 70% alcohol. Okay, another option is disposable stethoscope cover. Okay, if you have that, you can use that. So you have to wipe the stethoscope area. It is also should be done between patients or use designated stethoscope for infectious or high-risk patients. That's the other option. For thermometer, use sheet cover or wipe with 70% alcohol. Should be done after every use. Yeah. For stethoscope, otoscope handle, wipe with low-level disinfectant. Example, 70% alcohol or hydrogen peroxide of 0.5% wipe. So you can have wipes in your hospitals or clinics. Should be used in between patients. These are lists of harmful disinfectants or cleaning products effective against coronavirus. There are numbers of disinfectants which is quite familiar to us. Clorox disinfectant wipes, Dettol antibacterial surface cleanser, MediClean wiper is all in these. You can find this in the shops. Yeah. Another focus is actually on the exposure risk assessment for healthcare workers, because once patients were identified as confirmed cases, you have to actually do the risk assessment to your healthcare workers and categorize them in which category, whether they are high risk exposures, medium risk exposures, or low risk exposures. Okay, we will share with you this slide. Yeah, so because it's too, it's a slightly small. So it's actually, I will just read it. For the high-risk exposure, healthcare workers who perform or were present in room for procedures that generate aerosols and are likely to be fully controlled and on patients with COVID-19, and when the healthcare providers' eyes, nose, and mouth were not protected. When a GP procedure is there, their nose and eyes and nose are not protected, so they fall under the high-risk exposures. And for medium-risk exposures, the healthcare worker who had prolonged close contact with patients with COVID-19, and the healthcare worker mucous membranes and hands were exposed to potentially infectious materials for COVID-19. This exposure could place the exposed healthcare worker at risk of developing disease, and we categorize them as medium-risk exposures. The last is the low-risk exposures, which is actually to account for any inconsistencies in the use of or adherence that could result in the unrecognized exposures in fully PPE gown healthcare workers. They are using full PPEs, but they are uncertain of certain criteria. The third one, the last one is actually no identifiable risk. Okay. Healthcare worker with no direct patient contact and no entry into active patient management areas, and who adhere to routine safety precaution. These healthcare workers are not considered to have this exposure of COVID-19. Yeah. Okay. In terms of risk assessment and action to be taken, the first group who are actually having the high risk exposure group is the one who have unprotected eye, nose, or mouth. They didn't use any respirators. They perform or present in the room for procedures likely to generate higher concentration of respiratory secretion or aerosols. The examples is actually performing ventilation, on intubation, performing nebulization also. This recommended action should be active, in which they should be actually monitored. Work restriction Okay, this work restriction applies to everybody who are exposed in the high-risk group. They should be excluded from work and put on home surveillance for 14 days after the last exposure. Okay. In the other group is actually those healthcare workers who are not using a gown and glove, but they use respirators, but they perform or present in the room for a procedure likely generate higher concentration rate as ATPs. They are actually categorized the medium category, okay, and they should also excluded from work and put on home surveillance for 14 days. If you are actually facing this group of healthcare workers, you need to exclude them from work and give them 14 days home surveillance. The other groups are the low category. They are wearing face masks or respirator alone, but they have prolonged close contact with a patient who was wearing a face mask. Okay, patient is wearing face mask, the healthcare worker is wearing face mask. The category is low, so there shouldn't be any work restriction. They can come to work as daily. Okay, the next category is also a low risk. The healthcare worker are using all recommended PPEs, respirators, eye protection, gloves and gowns, and they were carrying or having contact with the secretions and excretions of a patient. It is low risk and there shouldn't be any work restrictions for this group of healthcare workers. Okay. For those who are not using all recommended PPE, but they have brief interaction with a confirmed COVID case, regardless of whether patient was wearing a face mask or not, it is also low risk, categorized as a low risk, and there shouldn't be any work restriction for this group of healthcare workers. And the last one is those healthcare workers or personnel without PPE. Okay, but they walk by a patient who have no direct contact with the patient or their secretion or excretion and no entry into the patient's room, meaning they don't have any contact with the patients. There is no identifiable risk for them and there shouldn't be any work restriction for this group of healthcare workers or personnel in the clinics as well as in the hospitals. With that, thank you very much. These are the reference from various sources for this presentation. Thank you.
Thank you, Dr. Soraya. So now, for your information, we'll be sharing the presentation slides via Twitter. And now we are moving on to the panel session. Here are some of the instructions. We kindly request all the participants to mute their mic. If you want to ask the questions, you can type on the text chat, or you can raise the hand in the video conferencing and we will invite you to speak. That will be the voice chat. So we move on now with the expert question and answer session. Our panelist today is Dr. Suresh, who is joining us from Sungai Buloh, Dr. Soraya Amir, who is here. We also have with us here Dr. Arasu Raju, the General Secretary of MMA. Thank you, Dr. Arasu, for joining us here. And Dr. Nazrila Hairizan Nasrin, who's the Deputy Director of the Family Health Development Division of the Ministry of Health, who's in charge of the primary care services. So with that, now I open up for questions and answer. You can also use the chat text where we will answer, and also you can raise your hands to speak. Yes, go ahead. Okay. Yeah, this yeah.
Right. One of the questions, is it wise to give azithromycin to URTI patient?
I should answer the question, right? Hold on.
Yes, Dr. Suresh. You go ahead, yeah.
No, it is not, because we don't know whether azithromycin monotherapy works. Again, and I think it's useless for upper respiratory tract infection because of viral disease. So we still have to know more, because it is just 6 patients. So I don't recommend anybody giving azithromycin for URTI. I don't think it's going to work.
All right, next question.
The next question is about,
What is your view on use of rapid test kit as screening tool?
is there anybody there? I mean, anybody from virology?
No, the virologists are unable to join us today. They are in a meeting. They're still at a meeting.
Fine. So what happened? The rapid test kits are antibody-based test. That's what I'm talking. When I say rapid test kit, I'm talking about antibody-based test, because there is a PCR test that is coming soon, based on a gene expert platform. I'm not talking about that. The current antibody-based test can't be used for diagnosis as of yet, because it's an antibody test, and it takes more than traditionally it becomes positive in the 2nd or 3rd week of illness. And so while our concern is trying to diagnose these people in the 1st week of illness, that's where they're most effective. And so diagnosing it later, there's no prizes for that. And so I don't think the rapid test kits are useful currently. We tested in Sungai Buloh, we just tested one kit, and we found it extremely, I can't remember the name offhand, but I found it extremely not very useful, because at day 16, only 65% of them were positive. At day 7, 0% were antibody positive, and so it was not very useful. I think there is some, in the next weeks, I think IMR will be testing some of the rapid test kits to get more data. So currently, we don't encourage using rapid test kits to diagnose COVID-19.
Thank you, Dr. Suresh. Next question. I read a report stating anosmia is a peculiar symptom of COVID-19 infection. Useful in any way, or should treat it as a warm water kind of information?
Honestly, I've not asked people. There are so many questions we have to ask. We can't ask them, do you smell right? Because they'll all be wearing a mask by the time I see them. And so I've not asked those questions routinely, but I think, I don't think it's diagnostic of COVID-19. I don't think there's anything that is diagnostic. So the usefulness of it, I'm not so sure. I don't think it's going to be useful.
Okay. Next question, Dr. In a GP setting, we don't know who we are exposed to. So what will be the most effective triaging methods? Temperature taking or travel history, or both? Please take note that in a GP setting, we are facing severe deficiency in even getting a proper surgical mask.
Yeah.
I think MMA has got a strategy. I think they came up with a video where we worked with them to come up with a video. Does Arasu want to answer that? I mean,
Yeah, Dr. Arasu, go ahead.
Yeah, thank you, Dr. Suresh. I think that's a very good and practical question. Rest assured, my fellow colleagues, that I'm also a practicing GP. I'm still seeing patients. Okay, basically what we have done is that we have done a video with Sungai Buloh Hospital with the help of Dr. Suresh and also Dr. Christopher, which is a basic of what should we do with our limited resources. That's one thing. Okay, that video is very helpful because it guides you step by step in the practical situation in the GP settings. Okay, the other issue is that we are aware that there is a scarcity of resources, especially on PPE, face masks, and also hand sanitizers. MMA is working very closely with the Ministry of Health. KSU is aware, the entire ministry is aware about that. And then we are trying to get as much as possible for the GPs. Okay, now the frequent questions asked by the GPs that what do we do in the event we do not have a face mask and hand sanitizers? Of course, the number one is that you need to maintain infection prevention control to your patients and also yourself. If there's an issue, probably you can use the guidelines issued by CCAP recently, that in terms of what you should do in that scenario, whether you cut down your hours or you close down, you have to refer to CCAP on that. The guidelines is out there. Thank you.
Thank you, Dr. Arasu. May I know your opinion on the statement that this virus is an airborne disease? Dr. Suresh?
Yeah, we know. We always knew it's nothing new. We always knew it's airborne. but it's airborne when we intubate the patient, meaning in an intensive care unit. It is airborne if maybe it's airborne if it is when we nebulize patients, we use nebulizers. But otherwise, the majority of the patients that we see in our wards, it is not airborne. And so that's a proof for us. Since the first day of Chinese New Year, we have been managing patients in our wards, and our wards are not prepared for airborne this thing. They're not negative pressure, nothing of that sort. And so we have not seen any virus transmission here, right? And so majority of the patients who are mildly symptomatic or just have URTI infections, the mechanism is droplet. Surgical mask protects you. Surgical mask with eye cover protects you. But if they're very sick, and if you're intubating them, or if you're maybe even if you're nebulizing them, it can be airborne. So it depends on the setting where it is. And so that's what it is now. So that's why the current current guidelines that we say, stay more than a meter away from patients, wear surgical masks, all still applies.
Thank you, Dr. Suresh. Dr. Nazrila, you want to add something? Go ahead.
Thank you, Dr. Fazila. Just going back to the GPs and the clinics, and I think even though we have, there are problems now, for example, on masks and so on, but I think as we have always been saying, that we always should ask the question, and now we are appealing to the public to also tell the truth. So we always tell them, tell us whether you are in contact, whether you are, before they come to the clinic, before they enter the clinic, give them that hand sanitizer, ask them to close their mouth, and when the healthcare worker comes into the room, and for us to always protect our healthcare workers and us as doctors, so that we always wear our masks and treat. And just think that everyone is a COVID patient, and just take the necessary precaution for every single of patients, even though we don't know whether they are positive or not, but treat them as if they are, so that we can protect ourselves. There's always a question on what happens if we are wearing our masks, we sanitize our hands, but one of the patients that came in was actually COVID positive, and suddenly we also developed symptoms after seeing the patient. I think I still need Dr. Suresh's opinion on this, but to me, as a healthcare worker, even though we are wearing our mask and have we think that we sanitize our hands, but if the patient that we saw is COVID positive and we develop symptoms maybe 3 or 4 days after that, I think we do need to get ourselves checked. What do you think, Dr. Suresh?
Dr. Suresh?
Yeah, I agree. I fully agree.
Okay.
Okay, next question. Any difference of technique used in IMR and private labs, example VP lab for COVID-19 testing, sensitivity wise?
I think Dr. Suresh.
Yeah. So I think the private labs and IMR and MKK came together for multiple discussions regarding the testing. The private labs, most of them use commercial kits. It is very tricky to compare sensitivity and specificity, because the single most important parameter in this whole viral load testing is the way you take your swab. If you don't take your swab correctly, then the test can be negative. And the second thing is, we know that the swab is not 100% accurate. So it just can't be just swab alone to decide. So there has not been a formal comparative test, but the labs are using commercial kits that are widely available. The protocols are widely available, and I think they should be reasonable.
Okay. Next question. Should we refer all URTI cases with fever more than 38 degrees Celsius, or when to refer?
Refer to whom? No, we can't. I don't think we can. So I agree with you. Eventually, the travel history is not significant, and anybody with URTI will become could possibly be COVID-19. So if that happens, then of course we can't test 30 million people once every 2 weeks. Every time they get a URTI, we can't go around testing them, right? It's not practical, right? So if that happens, you think about it, most people will do very well, right? Most people will do very well if you have COVID-19. The people who won't do very well will be the people who are elderly and people who have got comorbids. Okay, that we know. Right? The third thing is, if you are going to do badly, we will know why you're doing bad. Which are the group that are going to do badly? These are the ones who have got persistent high fevers. These are the ones who have got, starting to get maybe shortness of breath, exertional dyspnea. When they walk a bit, they feel short of breath, and persistent cough. If you have any of these danger signs, so to speak, then they should come and seek treatment. So if somebody comes to me with a URTI, they are not known to any of the clusters that we are having now. They have not come from a country that has got potentially a high rate of infection, which I think we have a tough time finding such a country. But if you have no such link like that, I would ask them to go home, rest, isolate themselves, show them what home quarantine is, home self-surveillance all about, tell them what are the danger signs, and vast majority will get better. Once they are better, then they can get on with their life, right? So 7 days or so. This is a UK NHS advice, right? And once they get better, they get on with their life. Right? And if they don't get better, then only we start testing them rather than testing every single URT. It's not a practical methodology.
Okay. Next question. Why not advocate chloroquine as prophylaxis to people out on home quarantine? And is it true that now source of infection can also be sporadic, no longer based on close contact?
Second question is, of course, we are seeing sporadic cases. We can't always find while majority of the cases are linked to some cluster, we're already starting to see sporadic cases. I agree with you. Number one, when you see the report, daily report, you can see how many of them are cluster related and how many are sporadic. That's one. The second thing is, as I mentioned earlier, we don't know whether it works as a prophylaxis. We have to wait for some studies. These are all theories. People have come up with lots of theories, but we don't know whether it's going to work in practice or not. So currently, I feel there is not enough data to say chloroquine, hydroxychloroquine can be a good prophylactic drug. But there is some data to say it is useful in mild to moderate disease. I just don't want to wreck this drug. We have very few drugs available now. I don't want to wreck this drug by putting it without any data as a prophylaxis drug. First, the virus might get resistant to it. Or the second, there will become acute shortage then, and then we can't use it for people that really need it. So I caution all of you not to go embark on prophylaxis and then make the situation that's already bad worse. Let's go by science, and the science says we don't have enough data to indiscriminately use it as prophylaxis. Okay? There is limited science that says we could probably start using it in mild to moderate disease, very limited science. And let's go by that. And all of you, we need all your help to make sure we don't waste this precious resources based on just rumors and popular and stories from popular media.
Okay, next question. Some private clinic do offer test kit to detect COVID-19. Is it advisable to do so under private clinic setting with just masks and gloves? How about as a screening tool?
As I mentioned earlier, rapid test kits currently cannot be used yet. We don't have enough data. The preliminary, very little data that we had so far tells us that it doesn't pick up people who have got early disease. And so we are actually UK NHS and we ourselves are now saying, please do not use rapid test kit for diagnosis as yet. It is being used as a public health tool, but not for diagnosis.
Next question, Dr. Suresh. 30-year-old doctor, pregnant at 5 months, exposed to a COVID-19 positive patient. She was wearing a mask, patient was not. Should the doctor be made to continue work? Second question, if a healthcare worker has underlying asthma, well controlled on fruitiform, and he or she is still fit for work at a GP clinic. PPE is being used at clinic. Is the patient exposed? Like the same question above.
Yeah, if the patient, if the person, I think Suraya went through those slides. I think you will have to download those slides and then go through the scenarios one by one and see which one fits. Offhand, I think I also go back because it's very confusing. I also go back to the slides to look at it whenever people give me a scenario, right? So offhand, if somebody, it all depends on whether the person, how close the contact was with that particular patient, whether he coughed on your face and stuff like that, right? But if it is a normal contact, if you have to wear a mask, you are protected. And so that's the reason why we are encouraging everybody to wear a mask. But there are nuances in it, right? And so we would interview the doctor in depth to decide whether she's at risk or not. So the general rule is, if we think it's a close contact, we'll ask them to go off work. But if they think it's a casual contact, we will ask them to continue work but monitor for symptoms. Well-controlled asthma, I don't think is a risk factor for as far as I know, it's not a risk factor for COVID as a vulnerable population.
Okay, next question. Any evidence on favipiravir in treating COVID-19? Have MOH acquired it? And do KKM have favipiravir tested here in Malaysia?
Those one of the drugs that we are looking at. There's some limited data from China saying that might be useful. We are trying to acquire the drug. Currently, the drug is not available in Asia. We are trying to get the drug from China currently.
Okay. Should we just close GP in view of shortage of PPE, and would this burden the KKM? And if all hell breaks loose and we come to a point where we are forced to reuse face masks, is there any way to disinfect or sterilize the mask used for personal use?
Arsu should answer that question regarding all hell break loose question.
Yeah, Dr. Arsu, go ahead.
I believe the infection part probably Dr. Suraya, Dr. Suresh can answer. But in terms of the practicality as a practicing GP, the country is facing a crisis. That's what we should understand. So we have 7,000 clinics in the country. It's time that we play our role. Of course, the infection prevention control is very, very important, because if you're not well, we can't treat the others. So let's use the basic things about what is the casual contact. So the basic protocol that I would advise as a practicing GP is that treat every URTI with a temperature above 38 as a PUI COVID-19 protocol. I said PUI COVID-19 protocol. That means you must train your staff at the counter that what are the relevant questions to ask. Keep a distance of more than a meter. Very short question. Prepare a simple script for them to ask a question. If the temperature is above 38, I would advise them to be sent to a separate room or a treatment room. Go there, wear your mask, don't touch the patient, just do a verbal triaging and also a visual triaging, then you decide. And 80% of our patients are repeat patients. That means we know about the patient's history. And most of them will tell us the truth. Okay, now the issue is that this could be those first-time patients who are coming, that could be 20%. So if you think there's a risk in your judgment during your visual and also verbal triaging, if you find there's an element of risk, then spend very minimal time and then send them out and give them proper and adequate information for them what to do. And probably after that, you can monitor the patient. They probably call them up after 1 day or 2 days to monitor. This is part of the CSR that we have to do, so that this particular person, if they do not fulfill the COVID criteria, but they're a bit doubtful, it's better to monitor them. So that would be my practical advice, which I'm also doing at the moment to reduce the risk in my practice. We have to continue to play a role. And then I think the government will now, MMA has issued numerous statements on PPE, and we have received, NADMA also has issued about the statement. And let's hope that this issue of PPE is resolved. At the meantime, remember one thing, we are all healthcare workers. We have gone through the training in a very difficult situations. Some of us in ED during the house management have gone through very minimal resources, and how do we manage that? So probably these are the skills that we have to go back and read and then try to do it. And the situation is very dynamic. And some of them have asked me also, can KKM come out with guidelines? To me, my personal opinion is that this is a very dynamic situation. This virus is very new, and all of us as healthcare workers, we need to also adjust according to the situation. But the most important thing, whatever we do, it must be evidence-based, and let's do not panic. If we panic, it's going to create chaos. Thank you.
Thank you, Dr. So perhaps Dr. Suraya can also mention something.
Okay. In terms of guidelines for the infection prevention and control, initially when we have our first version, second version, and third versions, our guidelines is actually more of airborne approach. The usage of the PPE recommendation is actually higher recommendations, but when we see that there's actually more of a droplets transmission, so our guidelines change. So our recent the coming up guideline will be version 5 in terms of exposure. So the risk exposure is actually based on the transmission based of precautions of droplets. So the PPE use will be it's not step down, it's just appropriate to the risk of that transmission base of droplets instead of airborne. So some of the some of the recommendation in earlier versions was not applicable anymore in our latest versions. In terms of the PPE, whether it can be recycled or reusable, so according to the standard, it should be, if it is actually advised as single use, it should be single use. But then, as we know that we are having problems with PPE, our Ministry of Health has actually worked with all these relevant agencies to coordinate in terms of PPE supplies for Malaysia, not only for Indonesia.
Thank you.
Okay, next question. I'm in a private hospital. Due to shortage of PPE, is it adequate to clean with soap, bleach and water to clean and reuse? And also, the virus size is smaller than the pores on 3-ply mask. So is the 3-ply mask of any evidential protection?
3-ply mask is actually adequate for, as earlier mentioned, that is actually droplets, so 3-ply mask is adequate. But if you are performing aerosol generating procedures, we need to change it to N95, which is actually, if it is in the clinic setting, it could be the nebulization, or if there is any emergency intubation, something like that.
Dr. Arasu, MMA with Pharma Malaysia only supply 50 pieces per clinic of masks. Definitely not enough for us with many branches.
At the moment, it's a very good question, practical question. See, at the moment, we are having scarcity of resources. We have 7,000 clinics in the country. We need to make sure that every clinic, their staffs and the doctor and the patients are protected. So that is why we are rationing at 3 boxes per clinic with 50 pieces each. So you must remember, we are having a crisis, and we need to acknowledge that we're having a crisis, and how do we handle it in this period of time. And then what we have also noticed, there is a significant reduction in number of patients in most clinics. Some are up to 80%, some on average, what we have gathered from the ground is around 50%. So it shows that there could be fear. So the usage also will be minimized a bit now. And then let us all work together in this time of crisis.
Thank you, Doctor. Is it better to use MDI inhalers rather than nebulizers under current situation? And is there any role for Tamiflu?
Yeah, it's not better to use MDI inhalers than nebulizers, because a nebulizer you can aerosolize it, and so can be airborne. And the second question was,
is there any role for Tamiflu?
Tamiflu. Tamiflu doesn't work for COVID-19. If they have influenza, it will work.
Thank you. Some Majlis Daerah are asking GP to close after 6 p.m., where else we are supposedly to close by 10 p.m. by CCAPS. Which one should we follow?
Okay, this is a legal question. So what can MMA do at the moment is that we will get the direction from the Ministry of Health, and probably we'll escalate this matter to the NADMA also, so that let NADMA make a decision, and then so that there's a uniformity throughout the country. At this point of time, I can't answer. We will communicate with NADMA and MOH and wait for the direction on this.
Based on WHO paper, isolation and quarantine itself will not control the infection. We need to do aggressive screening tests to actually have better results in controlling the spread of infection. What is our next step?
Dr. Suresh?
Yeah, fully agree. Fully agree. That's the reason why the lab people are not here for the panel discussion today. That's the reason there is a massive upscaling happening currently, and all universities and army, everybody is chipping in. Private labs are chipping in to increase the capacity for testing, and so there is a plan. So our DG is very clear. He wants us to test more so that we can identify and isolate, and we are upscaling our capacity.
Patients are not truthful and history is unreliable. Should we test for COVID-19 in every case with fever and URTI, assuming cost is not an issue? Same thing.
Yeah, the issue is lab capacity. So I'm saying, the number of people having URTI and lab capacity is not adequate yet. As of now, we cannot do it. I don't think our labs can cope. So that's the reason why I'm saying we all have to have a proper advice for these people. Isolate yourself at home, and so that you don't spread the disease to somebody else. And if you have any evidence of the disease, getting worse, contact us so that we test you as for the second round.
Hello. Hello, sir. Sorry, we've dialed in from KKM. Dr. Ravi is here to answer the lab.
Okay, great. Welcome on board. So we have two more of our panelists. Dr. Ravi from IMR and also Dr. Priya from
yes. And can I just add, we've got Dr. Hani from MKAK and Dr. Nick from OSH. There's 4 of us here today.
Oh, thank you. Go ahead.
We were in a CPRC meeting. We just concluded that, so we now can answer any questions.
Dr. Ravi, there was a lot of questions regarding lab.
I can leave now. No, just joking. Yeah, right. Regarding what exactly? Rapid test, is it?
There were questions on rapid tests and also our lab capacity to do mass screening.
Yeah. So basically, first I address the rapid test first. So rapid tests that are available in the market are antibody-based tests, right? So what does antibody tell you is actually tells you that you've been exposed to the virus. It doesn't tell you whether you're still carrying the virus. So that's the thing. Because you see, basically you have 2 types of antibody that can be detected by the rapid test. One is called the IgM, which usually comes out after day 6. And one more is the IgG, usually comes about 2 weeks. So let's say you take a sample on day 1. The person may be having the virus, but you may miss because it comes out negative. So basically, if you take on a day 6, you may see the IgM, but you don't know whether the person is still sharing the virus. The main aim of us doing a diagnosis test like PCR is basically you want to see whether the person is still sharing the virus so that we can contain them. So the antibody will not tell you that, because basically it will tell you a person has been exposed, but not necessarily carrying the virus. It's a reason. So, so back to our capacity of PCR. Basically, looking at how many hospitals that we have trained, IMR as well as MK, we have in total of 18 centers in the government facility. Government means Ministry of Health facilities that can do PCR. And then we also have trained private labs as well as university labs. And many people are coming in. But again, the capacity, basically we are, because we also have slight issue regarding reagents. Some reagents are coming soon in 2 weeks' time. So we are right now our capacity is about close to 3,000 a day, close to 3,000. But probably looking at the what number of cases that are coming, we have to ramp up maybe double or triple. So we are also looking at automation. Automation. A lot of hospitals have automation where we could quickly do the extraction through an automation system and put into a liquid handling system to get the result. We want to cut short the turnaround time, but and also the reagent lab. We have to do all that when you have enough reagents as well as basically reagent. So we are also looking at other options where there are companies who are coming in now, new players, where they have high throughput PCR machine, where you can run 96 samples at one go. One is coming from Singapore. They're going to come to IMAR tomorrow. We will set up the assay, and then if it's working, we probably will send to this kind of platform to high throughput centers like Sungai Buloh need a high throughput center as well as MKA, provided they have this. I mean, I think most of them have the existing system, the real-time system. And another maybe a bright news, something that we've got hold, that there is possibility of a rapid antigen test. This is what we want, not an antibody test, a rapid antigen test, which will use it. Basically, how it works is that you take swabs from a nasopharyngeal swab as well as oropharyngeal swab, and straight away put into a buffer, and it is a 10 or 20 minutes test, just like a rapid test, which can be done in a hospital setting. So if we can get hold of that, apparently some Korean company have developed that, but we have not come to Malaysia yet. That we are willing to do evaluation. So we will probably, IMAR people will go and see Dr. Suresh. We'll do it on site because this must be done in the hospital, because basically the swabs that are coming is usually in what we call as viral transfer media. It's not indicated. You cannot use a viral transfer media to do that. You have to use the buffer that's provided by the rapid test. So which means you must do on site, which is very good for the hospital. It is good even basically again, when you take the sample, there is also certain SOP to ensure the person who's taking up the sample has to protect it, because you're going to use nasopharyngeal as oropharyngeal. Once you take properly, then straight away transfer. That kind of training we will provide. Like, first of all, we do that for Singapore Hospital, and it's a simple test. But basically, once you take a video or something like that, then we can distribute. But having said that, first of all, we have to have that thing first. So using that kit, that rapid test, even though let's say its sensitivity is 50%, say you take 100 samples and you do 50% positive, it's good. At least you can bring down the turnaround time from PCR, which takes about, because PCR there is a few steps, and there is also activation, inactivation, there's extraction, and there's PCR. In a good time, you can get it about 4 to 6 hours. This rapid test, you can get it out within half an hour. So if let's say sensitivity is 50%, it's okay. 50% you can take report, and the other 50% you can put them for the PCR, which is more sensitive. So at least you break down, at least you bring down 50% of the workload from the labs, right? Basically something like that.
Thank you, Dr. Ravi. Next, I think I just give Dr. Priya to maybe briefly touch on health and safety of our healthcare workers.
Okay, thank you. Are we referring to our healthcare workers or to the GPs?
No, all. I mean, all.
Or to all, right. So currently for healthcare workers in general, I think if you look at our interim guidelines, as Dr. Suraya has mentioned, I think earlier, so the PPE has been recommended for the use of the doctors. Now, but the PPE recommended for treating COVID positive cases are full PPE as listed. For now, what we are saying is for those treating other cases that are not, sorry, you cannot hear, is it? That are not COVID positive, then we are recommending that the 3-ply mask be used. But the most important thing that we would like to recommend to the doctors, I know private may be a little bit different, you need to adjust your situation accordingly, but the 4 important things we would like to highlight are, if you get a patient, I think Dr. Suresh is there and we concurred on this. So if you get a patient with symptoms, make sure the patient is given a mask, right? This is maybe in a hospital or other setup. And of course, you have to practice your distancing. And thirdly, you have to have very strong, good, frequent hand hygiene. And last but not least, you wear a 3-ply mask as a doctor. This is the minimum most for cases that you should protect yourself with. So by right, if you do follow, meaning you adjust your situation accordingly depending on the patients who come. Okay, if it is a GP setting, you can do your triaging, and then if your people are protected, your patient comes in, you should only be doing a symptom screening at the GP clinic. You are not actually asked to examine, after which you can refer the patient. So therefore, I think we should avoid panic. Most importantly, try to follow the instructions given, and there's no need to, jump. And PPE is limited right now. Even Ministry of Health is finding it very difficult to procure PPE. That is why we would like to recommend judicious use of PPE. Try to use it, the mask cannot be used after every point. You have to maintain it until, of course, it is contaminated or it is damaged. And of course, when you don't handle it, when you remove it, I mean, there are a few things you have to do for judicious use. But at this point of time, that is, I think, of note. that if everyone can try to follow what we're recommending, hopefully it should be okay.
Thank you, Dr. Priya. I think we have 10 minutes left. I will answer a few more questions here. Go ahead.
Okay. Next question. If GP close shop, what type of volunteer position with MOH can we consider? And is it necessary for us to wear gloves during consultation?
Go ahead, Dr. Priya. Who will take this question?
Yeah, okay, I've seen that. Yeah, we are asking for volunteers. Currently, the request for volunteers is not to immediately place them in any location. The request for volunteers is to stand by. We would like to stand by volunteers who can assist us if we come to a point where we cannot manage. And having said that, the volunteers themselves also would not be actually used to manage COVID positive cases. The volunteers where the help of doctors are needed. So since they are being used in other settings, the mask alone should be sufficient. Anyhow, we will be giving the recommended or the recommendations to the volunteers based on where they are placed. So I think there's a misconception that the volunteers will be used to treat COVID patients. That's not true.
The turnaround time, acceptable turnaround time.
Okay.
Is there a question regarding acceptable turnaround time? Actually, the best would be within 24 hours. That's why we are doing trying to do that. Our data shows almost 80 to 90% we still get it out within 24 hours. That could be some, can go up to 40 hours. But that's the reason why we are going into automation and getting the high throughput can bring down the turnaround time even to less than 24 hours. Basically, how some of them work is basically when the turnaround time actually calculated the time we receive a sample at the lab, then and the results out, not from the field you collect sample. Basically, there's some actually we release within 12 hours. Let's say we get in the morning at 10 o'clock, we release by evening. So it's even less than 24 hours. So it goes by a higher throughput when you have more sample. There might be, but we try our right now is almost 90% we release the result within 24 hours. We're trying to reach 100% less than 24 hours. That's our aim, ultimate aim. With the automation, with a lot of people days coming, we hope to achieve that. Again, when you say that, when you are looking at people who are waiting for the result, they are already contained. We are not releasing them. So they are already contained in certain specific sites so that when the result comes, then we know what is the management like.
Anything to
It's like now you did it. And hello. Apa tu? Yeah, no more connection.
Hello, I think we are disconnected. Sorry. Are they connected?
They can hear. We can hear. Don't worry. All right.
Oh, okay. So we don't know which question is being discussed. Sorry.
It's just a quick question on drive-through screening centers and self-swab. It's about drive-through and self-swab.
Somebody is doing. Somebody is doing right. Yeah.
Yeah, so we did try. We have done drive-through. I think many of us have done it, and also I think Bilaya did it also, a drive-through testing for people that we know who are coming through. And self-testing, yeah, I've not seen any because I've not seen data for self-testing yet because it really requires a nasopharyngeal swab, not a throat swab, oropharyngeal swab. I've not seen the data for self-testing as yet. Most testings are performed by somebody.
So, how do you take the swab properly? Yeah, just a bit, because the indicated sample collection is actually usually nasopharyngeal swab as well as oropharyngeal swab. you may not get a high yield, so you may miss out. So it's not recommended crop swab.
Okay, thank you. Dr. Suraya, go ahead.
Okay, I would like to add on about the usage of glove. It is not advisable to use glove as a universal gloving because it actually can contaminate other surfaces. Instead of putting glove on, you can actually use frequent hand hygiene. So glove is only for collecting samples or when they do the cleanings and so on, but not for the usual physical exploitation, which is more of use hand hygiene instead of glove, except you are exposed to the body liquid.
Thank you. Any more questions? Go ahead.
Okay. How long is the incubation? No. How long should we adhere to house quarantine? Asymptomatic casual contact and asymptomatic casual contact, judging by the fact that incubation period can range from 5 to 14 days and the disease progression is up to 26 days.
Yes, Dr. Suresh. Dr. Suresh or Dr. Priya?
Sorry, repeat the question again. I didn't get that.
Okay, how long should we adhere to house quarantine? Number one, asymptomatic casual contact, then symptomatic casual contact, because judging by the fact that incubation period can range from 5 to 14 days and the disease progression is up to 26 days.
It was asymptomatic. It doesn't matter asymptomatic or symptomatic, right? And so if you have a contact, your clock starts from the day you're no longer in contact, right? Isn't it? Huh? So when you're no longer in contact, from that day onwards, you count 14 days. And so if you're going to get the disease, you're going to get the disease in the next 14 days. That's what the incubation period is about, right? Once you get a symptom, then you can progress. But if you're getting better, then that's it. It's still 14 days.
Just a question on that, because we also are looking at using an alternative test for those home surveillance. Say day one, they have done a PCR and it's negative. We also again will be doing a day 13 PCR. But because looking at seroconversion, by day 13 you should have an antibody ready, either IgM and IgG. So basically, we're going to use a rapid test, antibody test for them. For the day 13, let's say if it's no antibody and IgM and IgG, that's good. That means we can no need to do a PCR for that day 13. So that's how we're going to further reduce the burden on the lab to do a PCR.
I just would like to add something. For the doctors who had used the PPE, we will not consider you close contact. So I think people have a misconception. So it's those who have not been protected that will be considered as close contacts. All healthcare workers who are protected have taken the necessary precautions. We don't consider as close contact. So I think there's some misunderstanding over there.
Next. Okay. Next question. Are private hospitals allowed to treat COVID-19 patients for those who have medical insurance?
Currently, no. We have discussions to change that. Like currently, no. We are being referred to the government hospital currently.
Okay, we have 2 more last questions before we close the session.
Would you consider money as a factor that transmits the virus and encourage use of e-wallet?
Perhaps Dr. Suresh or Dr. Priya can take up this question. Transmission through money.
We have to do a scope on the money and look at the virus, something like that. But not, I know some people do share photos of washing the money and all, but I really don't know because really no evidence. We probably have to selectively take swab from the money and we see a virus probably that. We really don't know whether a person and then touches that. Could be, I don't want to say anything until there's evidence.
I think last question. What is the risk of examining the throat of any patient with febrile URTI?
Yeah. They have to take the PPE.
Wear a mask and do it. I think anybody should check anybody's throat without wearing a mask, and if necessary, an eye protection too. A mask and an eye protection is required before you check anybody's throat in this current time.
Dr. Straya, you want to add something?
I think if it is, if you are exposed to this droplets very near to the patients. And then if you actually anticipate it is aerosolized, you need to wear N95. If it is not aerosolized, meaning it can be just surgical mask. For aerosolized, another addition is actually your face shield.
Thank you. So as we are coming to the end of the session, I will allow each panelist to just give one sentence. What is the message you would like to give today? Perhaps we start with Dr. Suresh. Go, Dr. Suresh.
I know it is difficult times now. We might go for lots of. We will forsake science at this time. I beseech you all to stick to science and follow what scientific evidence there is out there.
Thank you, Dr. Ravi.
Yeah, we hope, because I know we hope with the new availability of methods, and we hope to screen more people. With that, we hope to contain more people. Hopefully, we bring down the curve, flatten the curve, basically that. At the same time, we want people to stay in the house when they basically that.
Thank you, Dr. Priya.
Basically, we will update everyone from time to time. Our guidelines are being updated according to the phases. I know it's one sentence, but just a quick one since we joined late. Our phase is changing in this whole outbreak. We are going towards a late containment mitigation. So I think everyone needs to change their way of thinking when they handle the cases. And at the same time, if they follow the precautions that we are recommending, it should be all right for the doctors. But I need to just mention, we cannot put everything down in detail. So whatever we give is the minimum most and the generalized information. So please kindly modify it according to the situation where you are in. But feel free to contact us if you need any further clarification in any matter.
Thank you, Dr. Priya. Dr. Suraya?
Okay, I think standard precaution and transmission risk precaution is very, very important at this time, in which we cannot know which patient is actually having close contact, or those who actually have traveling history and so on. So it is very, very essential for us to practice standard precaution as well as transmission risk precaution.
Thanks, Dr. Suraya. Next, Dr. Nazrila.
Right. I think, as I said before, and I'd like to echo Dr. Suraya, is that please take as all our patients or all URTI patients as a COVID patient. Take care in terms of our PPE, and please look out for our next guideline, because it's going to come up soon. Look at our website and please update, because it's changing at each time. So please keep yourself updated. Thank you.
Thank you. And finally, Dr. Arasu, your final parting message.
My fellow GPs, I think this is a time of crisis. Fellow GPs, this is a time of crisis. This is a time of crisis. Let's stand together with our colleagues in MOH. Let's enhance our skills in terms of verbal and also oral triaging, and then protect ourselves, stay safe, and continue to play the role of frontliners. Thank you.
Thank you. Thank you all. So we have come to the end of the session. We will answer all the questions posted on the chat space for those that we have not answered yet. And also we will be distributing the presentation slides via Twitter. Again, thank you so much for all our expert panelists today, both and also to MMA and also the National Institute of Health, Ministry of Health, for making this happen. And to all our participants out there, thank you for joining us today. May we all together strive through this crisis and flatten the curve. Stay safe and goodbye. Yeah.
Thank you, doctors.